For those of you all that do not know me, my name is Sharon Connors. I'm the Vice President of Diversity, Equality, and Inclusion at Micron. And I'm really excited to have this discussion today. This is part of our 4-part series that we put together to really tackle some of the issues we're facing around COVID. So today we're talking about health equity. And so for those of you all who may not be familiar with that term, simply put, what that means is that everyone has a fair and just opportunity to obtain their highest level of health. And we know that, or what we're seeing as we're going through this experience with COVID-19 is it's really amplifying some of the pre-existing social inequities tied to race, class, and access to healthcare. So I've invited 2 experts with us today to really share with you all what they're seeing and to talk about some of the solutions we all can participate in to really help to push towards health equity. And so with that, I'd like to introduce you to, first of all, Dr. Fola May. Both of these panelists, by the way, I want to say have very impressive backgrounds, so I'm very excited to present them to you all. Dr. Fola May is an assistant professor of medicine at UCLA. She is the director of quality improvement and gastroenterology at UCLA Health and is the co-director of UCLA Global Health Education Program. In addition, she is a clinician in the Veterans Affairs Healthcare System and serves as the Director of Internal Medicine for Seed Global Health. Dr. May graduated from Yale University with a degree in molecular, cellular, and developmental biology. She then matriculated to the University of Cambridge, where she obtained a master's in epidemiology, studying the obesity epidemic and international systems of healthcare delivery. She attended Harvard Medical School, where she became involved in health disparities research and global health. So the perfect person to join our panel today. And in addition to Dr. May, we also have Sean Mehra joining us. Sean and I have known each other for quite some time. I consider him a great friend and someone who's very passionate about health. So Sean is the Chief Strategy Officer and founder of HealthTap, and he'll tell you more about that today. It's a digital health company dedicated to creating universal access to quality healthcare for millions worldwide. Sean earned an MBA from Stanford Graduate School of Business and a BS with distinction in biomedical engineering and pre-medicine from Yale University. Sean is a futurist by nature, an innovator at heart, a scientist by training, an engineer by trade. We love that, Sean, and a designer by hobby. So I'm excited again to have these 2 join our panel. And I thought I would kick it off by asking a fun question, since this is a rather heavy topic. So Sean, I'm going to start with you. If you could have dinner today with any famous person, past, it could be Prince, or present, Beyonce, who would you have dinner with and why?
Oh, that's a great, fun question. Oh, man. Well, I feel like this is not well thought out, but the one that is top of mind for me is Kobe Bryant, just because I feel like I didn't pay enough attention to him when he was already one of the greatest of all time. And as I dug into his biography and just started paying attention to all the inspirational quotes that he's kind of sprinkled up throughout his career, I've just been really drawn to him as a person. And I'd love to take him out for dinner and learn about what his vision was for inspiring youth.
Wonderful. Awesome selection. All right, Dr. May, I'm going to give you a different question. So if I were to wave my magic wand and lift the COVID-19 restrictions today, where would you go? Anywhere in the world? Who would you go with and what would you do?
Well, first of all, I want to just say that the Kobe Bryant answer was phenomenal. I'm an anti-Filipino. I grew up in Los Angeles, and Kobe Bryant went to prom with Brandy the same year I went to prom, and I was very jealous of Brandy. We all are still feeling the pain of losing Kobe early this year. How bad has this year been? But to answer your question, I think right now I'm all for things that bring comfort because we are going through this really challenging time. So I actually would probably go to South Africa because it is my favorite country in the world. I've been there several times, and despite traveling all over the place, it's the place that brings me the most peace, specifically being in Cape Town or the Winelands, just relaxing with my family. So that's what I would do.
Gosh, that sounds wonderful. I would love to do that as well. Okay, so there is so much information out there. I was looking online preparing for this call, and I saw some startling statistics. One that really hit me was in 19 out of 24 states, we are seeing that African Americans have a higher rate of death. We're also seeing that COVID-19 is impacting Black and Latino populations disproportionately, which is really concerning. And so, Dr. May, there is so much information out here. What can you tell us about this virus that we all should know?
Sure. So I think the really fortunate thing about this time is that it's brought much of the world together. And it's also brought a lot of people to the news, in that people are more aware of what's going on. The unfortunate thing is that there's so much information that often it's hard to know what to pay attention to. And also along those lines, some of it is misinformation. So a lot of what we're doing in healthcare and at health institutions like UCLA and some of the other organizations that I've helped for is just make sure that the right information is getting out there. We know that COVID-19 is a disease that is caused by a novel coronavirus. Coronavirus is a family of viruses that's been around for a long time. They're not anything too new to the world. We've seen them forever, but this is a novel one. This is the first time we've seen this specific strain. The origins of the virus are still very unclear, but we're pretty sure that it was zoonotic spread from animal to humans. Sometime in probably November or December of 2019. And that's where the 19 comes from in COVID-19, is that it first appeared in 2019. It's spread through droplets that are released in the air when an individual coughs, sneezes, even speaks. There was a very interesting video in the New England Journal of Medicine a couple weeks ago that showed an individual just speaking, and they used a special kind of lighting that highlighted droplets coming from this individual's mouth. And you can see that just from speaking, there are droplets of potentially virus particles that are spread. And what is so interesting about this pandemic and why it has impacted us the way it is that COVID-19 is as highly and as infectious as H1N1, but is also very deadly, like we saw with SARS. And because of that, we're seeing the heavy toll that this virus has taken on the world and causing this pandemic. Right now, I think when I looked at the estimates this morning, there are 3.6 million cases. That's incredible. And over 250,000 deaths that we're seeing globally. We know that everyone's been impacted by the virus, whether you've had the disease, know someone with the disease, your economy is shut down, your world has been changed, you've lost your job. But we know that there are individuals, as you mentioned, who are affected more than others. And what we've been trying to do in a lot of research centers is understand who is being impacted by the virus, how they're being impacted by the virus, and then how we can offset some of the disparities that we have seen. So, for example, we learned early that people who are above age 50 to 55 are more likely to get the virus and to die from the virus. We also learned early, and this isn't publicized much, that males are more likely to have bad outcomes from the virus, as well as individuals with high comorbidities, so heart disease, lung disease, diabetes, overweight. People who already have these underlying predisposing health problems were more likely to fare poorly when contracting the virus. What we've noticed recently, as the tidal wave has hit the United States, is that there are also disparities by social economic status, so how much income you have, where you live, and also by your racial or ethnic background. And there's a couple things that have come out recently in the United States data. We know that African Americans take up about 13% of the population in the United States, but African Americans have suffered 27% of deaths from COVID-19. And in some states, it's more remarkable than others. So when we look at states like Kansas and Wisconsin, for example, African Americans are 7 times more likely to die than white Americans from this disease. And then you look at other states where it's a little bit closer, the disparity. Nonetheless, overall, African Americans are more likely to die from this disease. Interestingly, we're not seeing the same exact relationship with our Hispanic, our Latino population. What we're seeing is that Hispanics represent a larger proportion of the population, but the proportion of deaths from disease is actually at the same level of their representation or slightly lower, which is very interesting and is also one of the things that we're looking into why we're seeing the disparities negatively impact African Americans more than we're seeing Latinos. The other group that we're seeing a huge impact in is the Native American population. So it's a small population in the United States, but historically has seen a lot of disparities, whether it's heart disease, tobacco use, lung disease, but now also COVID-19. We know that we have over 3,000 cases of COVID-19 in the Indian health system, which is a separate private health system that's for our Native American population in the United States. The majority of these are within the Navajo Nation, but we know that other populations are impacted as well.
Dr. May, I actually had a question for you. Do you believe that some of the differences we're seeing in the African American population versus the Latino population could be explained by comorbidities, which obviously affect outcomes with COVID?
I absolutely do.
Yeah.
I think that on the surface, there are factors that are likely contributing to a lot of the disparities that we are seeing, but underlying this, there are deep roots of disparities in the healthcare and how healthcare is delivered in the United States that are driving these disparities. So, we talk specifically about African Americans about high comorbidities. So African Americans are more likely to have asthma, diabetes, tobacco use. There's higher rates of overweight and obesity for African Americans. But the other things that are playing a role are that African Americans are less likely to access the healthcare system. There's more mistrust. There's a lower likelihood to seek healthcare when ill. There's less knowledge about where to seek appropriate health information. Things that are similar among African Americans and Hispanic, but seem to be impacting African Americans more, are the types of jobs that individuals have. So who are essential workers? Besides doctors, nurses, firemen, and policemen, it's your janitorial service, it's your UPS, your FedEx, the people who are collecting our garbage for us every day, who are working in our grocery stores that are essential jobs. And these tend to be underrepresented groups and women. So we think that the disease is affecting these individuals because they happen to be out in the air, literally exposed to individuals that are carrying the virus more.
And we had thank you, Dr. May, for sharing that. We had a question, what is comorbidity? Shawn, did you want to explain for everyone?
Oh yeah, the purpose of my question was to ask if the presence of other medical conditions might explain whether certain groups suffer more deaths than other groups. And when you look at these comorbidities or other medical conditions by ethnicity, you'll find that certain groups like African Americans are more predisposed to heart conditions or diabetes, and that may factor in, along with many of the other reasons Dr. May stated.
I hope that answers the question, but I think that's exactly right. It's just, unfortunately, when you have someone who already has a high number or high burden of medical problems, particularly in their lungs or their heart, this disease is more likely to result in death.
Shawn, some of our listeners today may not be familiar with HealthTap or even telemedicine just in general. Can you share more about HealthTap and how virtual care is helping to fight COVID or playing a role in crises?
Yeah, definitely. And as this whole discussion is centered around the idea of health equity, I think in healthcare, that really boils down to the word access, which you've already heard us throw around a bunch of times already in this conversation. And access just means, can I get the information and guidance that I need in time to make sure things don't get worse? And there's a lot of things that come in the way of access. There's Sometimes you can't afford the care. Sometimes you lack the motivation or education on how to seek the care. Sometimes you don't have the time, or the healthcare is not proximate enough to where you live for you to get the care. And all of those really are addressed by this idea of virtual care, telemedicine. So a lot of people throw around this fancy word telemedicine more recently than not, but the idea has been around for a very long time. The first telemedicine visit that was ever done in this country was probably over 100 years ago or so, when the telephone was invented and a doctor picked up the call and spoke to his patient. And all it just means is you should be able to talk to a healthcare provider without needing to see them physically in person. And what's changed?
We're scheduled for.
Oh, what's really changed in the recent years is you no longer have to rely on just some telephone call. You could actually use an app or a website to make sure your doctor has their medical records in front of them. You can actually FaceTime and video with the doctor. The doctor can actually transmit a prescription, order a lab for you, maybe look at the metrics that come out of your Bluetooth scale sitting in your bathroom, and really use a lot more data and a lot more of these electronic connections to make that care complete that you couldn't do as easily just by a telephone call. So a lot of apps are coming out now to facilitate this video or text chatting with a doctor with all these bells and whistles attached to it. And HealthTap's mission has always been to create universal access to healthcare. We kind of approached it from a really interesting perspective that we already touched on, which is all of this misinformation. And this misinformation is a bigger problem now than ever with COVID, and all of these WhatsApp forwards and social media posts and sensationalist headlines from the news that we're seeing. We don't know what we can trust and not trust. But that issue's been around for a long time. And it's what people usually do is, before they go and talk to a doctor, because, hey, that's expensive, that takes time, a lot of people turn to the internet and they'll go to search engines like Google and they'll start typing in their health question. And when you look at the statistics around that, it's pretty startling. There's something on the order of 500 million doctor visits in this country every year. And there are almost 20 billion Google health searches every year. So it is 20 to 40 times more common that people will go to the internet to get answers to their question than speak to a credible medical expert. And unfortunately, the way the internet's constructed is anyone can say anything about anything. And so it's very hard for you when you're browsing the internet to know what is a trustworthy source and not. And even when you identify a trustworthy source, it's not usually answering your question, right? If you find an encyclopedia article that you think is trustworthy, it's usually going to answer really basic things like, what is this condition? How is it treated? But sometimes you have really practical personal questions like, hey, I'm curious if how long COVID-19 survives on the package of my Amazon cardboard box that arrived in the mail. Or is it safe to eat sushi during pregnancy if I'm a diabetic? Very specific question, very hard to find trustworthy answers for on the internet. So when HealthTap started, we actually started with that problem, which is, how do we create equity in access to trustworthy answers to people's questions by doing something unique, which was, instead of just having a private call with a doctor, which, even if it's virtual, it costs money, it takes time. Can we create a forum where you could ask questions and read answers and make sure all those answers are from trustworthy doctors and they're for free and they're at scale? So the way HealthTap started was actually with this really unique idea that you could submit your question to a crowd of doctors that are all trustworthy. They would answer your question, but instead of just helping you, they'll publish their answer on the internet. So the next time someone like you has the same question, that next person can be helped instantly. Because when they go off searching on the internet, that same exact specific question, they're going to find it for free instantly. And that creates a level of access that is novel and interesting. And of course, we do the virtual visit piece. Just to wrap up, I think what virtual care is doing right now is it's making healthcare more affordable. So it's removing that cost barrier. It's removing the geographic constraints of medicine. So if you live in a rural area or you need to talk to a doctor who's not in your state, like a specialist, all of a sudden you can, right? It's removing some privilege that some people had, which was maybe you're related to a doctor or have a doctor in your family and you can call them up whenever for a free or cheap, consultation at any time in the night. All of a sudden, the rest of America has access to this as well. So I think virtual care isn't something that all of a sudden is going to happen that wasn't going to happen before. I think COVID-19 just accelerated our future and is going to make it more commonplace more quickly.
Shawn, you said something that really piqued my interest. You talked about data and getting all these questions coming in. So I'm curious, this is a question for you and for Dr. May. We're a data-driven company, right? How are doctors and the healthcare profession using data right now? And is it important to collect data related to race, ethnicity, gender, as we're looking to fight COVID?
You want to go first, Shawn? Or?
Yeah, there's this really trending term in healthcare right now called social determinants of health. And it's an idea that basically says, the typical medical record that a doctor looks at has things about you like your age and your gender, sometimes a lot of ethnicity, but most of the time it's just medications, allergies, conditions, family history type stuff. But what we're beginning to realize is the type of job you have, the amount of income you make, the level of education you have, how many people you live with in your household, what kind of foods you shop for in the grocery store, what places you go to do your grocery shopping, all have major impact on your healthcare. And that's data doctors previously were not paying attention to and are now realizing have great impact on the course of treatment and plan that they create for patients. One of the things we really try to do in our app, at least, is make sure the profile that the doctors see about you is richer than just the typical stuff you see in a medical record. So we'll collect things like, how often do you drink or smoke? How, collect information about your friends and family, because they do matter. So Dr. May, I don't know if we want to add anything to that or a different point altogether.
I think for those of us who've been working with patients and data and social determinants of health for some time, this isn't new to us. So it's actually been quite funny to hear in the media people explode about health disparities and lack of data. We have a big data problem in the health industry. And what it stems from is the fact that we just don't collect it, as Shawn alluded to. When we first started seeing information about COVID-19 and who it impacts, there were no characteristics that were tied to a patient's social determinants of health. We didn't know anything about income, education, race, ethnicity, level of or their background or where they lived. It was just the country or the town that they lived in. And of course, a lot of that was a result of the fact that most of the countries that saw the tidal wave of COVID first didn't have such variation and diversity as the United States. But then when it came to the United States, we started to see that this virus isn't affecting everyone the same way. It's not just age or gender. There are other factors that are playing a role that are likely tied to someone's living conditions. And the key thing is that these health crises are going to impact the most vulnerable groups in most situations. And because in the United States, we have so much variation in how we live, eat, drink, obtain our income, we're seeing such dramatic differences in how COVID's affecting the population. What we know, and we've known for a long time, is that in the US, we've never done a great job of collecting data about race and ethnicity. Actually, it wasn't until very recently that the census has categories that are more granular about what racial background you are and what ethnic background you are. And when I say ethnicity, I'm specifically referring to Hispanic and non-Hispanic, whereas race refers to white, Black, Asian, Native American, Hawaiian, Pacific, etc. But those questions didn't even exist in the census until recently. So we didn't have the data to even look at these differences. even now, I mean, I've got a friend who works at the CDC, and we trained together in medical school. And when we were seeing COVID-19 in early March in the United States, we couldn't really tell that it was really disproportionately affecting African Americans because the hospitals didn't have race. The hospitals were very good at reporting the number of cases they saw every day and the number of deaths they saw every day. But when the CDC asked them what was the racial or ethnic background of these patients, they often didn't know. Something like 70% of the data was missing. And as we all know, missing data is a problem. So data is important. We're getting better at it. There actually have been gobs of money coming from NIH and other funders to help us better collect data. Some of the initiatives are coming right through the UC system, where we're asking hospitals to do a better job of telling us the race and ethnicity of patients that not only are diagnosed with the disease, but also that pass away from the disease. The other area that comes to mind that stands out about data is this process of reopening that we're entering now, I think can be very data-driven. We've seen out of Asia, for example, that they've been able to do things like contact tracing through cellular phones. Now, I know we're probably not going to get to that in the United States because everybody wants their privacy and doesn't want to be tracked by their cell phone. But thinking about creative ways that we can use data about where people have been, where they shop, where they order food from, what other exposures they've had to trace the outbreaks as they happen again. Because unfortunately, we are headed to a situation where we're likely going to be seeing a lot more COVID-19 until a vaccine exists. So I think those are a couple potential areas where we can optimize how data is used to combat the virus.
Thank you. Thank you both for sharing. We are starting to see a lot of changes as we go through this experience. One example is we're all on Zoom today, although my Zoom camera isn't working. And I'm a person who tends to be a slow adapter, but I find that this crisis is really pushing me to accelerate, right? So I pay with cash, but not so much anymore. We're starting to also see an uptick in people utilizing telemedicine. I'm curious to know what else, like what other changes have you both seen, and what do you think will stick, and where are you concerned will remain the same?
Yeah, I mean, I can start. I mean, I've been telling people that the world as we know it, you know, we're not going to be back to what we call normal for a while, if ever. And I don't say that to scare people, but I think it's the reality that we have to face. I mean, I used to think it was funny when I saw people wearing masks in public, okay? And look at us now wearing masks in public. I remember when people were talking about, oh, we're going to have to shut down the country, and then Italy shut down the country and Spain shut down the country, and people were saying, but that wouldn't happen in America. Look at us now. We definitely shut down the country. So I think the reality of COVID-19 is that we are seeing realities we never thought we would see before. And that's okay. I think we have to embrace that. I think we have to realize that it's for the safety and for the betterment of our world and of our society and our economy and our health. People are going to be wearing face masks now, and I think they'll be wearing them for the foreseeable future until we have a vaccine. And I know that there are individuals who would like to say that we're going to have a vaccine by January. I think that's highly unlikely. I think it's going to be 18 months before we see an effective vaccine and disseminated into practice, because it's not just the scientific intel, it's the clinical trials, but also getting it into the hands of providers who can then administer it to patients. That takes some time. And every timeline I've seen on every conference call about this topic has put this timeline further out than I think that we want to hear. I also think that we're not going to see large gatherings. My husband is very depressed that this has impacted the NBA season, because he usually is flying up to San Francisco or Oakland previously 3 or 4 times a year to watch a Warriors game, and that's not going to be happening this year. Fortunately, you know, we have some very innovative leaders in the NBA and in the NHL and a few other leagues who are talking about ways that we can broadcast sports without fans, and maybe that will happen in the next few months. But we're not going to have tens of thousands of people at a sporting event, at a concert, at a festival, even at a conference. And I think for the medical industry, that's been a shocker. I travel three times a month typically to medical conferences or meetings. Those have all been canceled. So there will be a loss of intellectual growth unless we can find ways like Zoom and other platforms to make sure that we're still fostering education and growth and moving forward in innovation. So that's why these platforms are so important. The other thing I'll mention is that I think schools has been a big issue, and we've been doing a lot of consulting here at UCLA to the LA Unified School District about what they can do with tens of thousands of kids out of school. And school is not just education. For a big portion of the population, school is 2 meals a day for a child who wouldn't normally have access to a meal. School is childcare for children whose parents are essential workers or who will need to go back to work to pay for their rent to stay in their home. So there are many downstream impacts of closing down schools. So we're talking about staggering class times, having small group school settings where maybe a few kids come 3 days a week on Monday, Wednesday, Friday, and a different set of kids are coming to different classrooms with a different set of teachers on Tuesdays and Thursdays. And I think that model is something that can be considered in many different industries, but we're talking about it in school, we're talking about it in the film industry as well. And then the other thing that I've heard a lot of conversation about is airlines, right? I mean, at some point, people are going to need to travel. They're doing some temperature checks. They are doing some screening. A lot of the airlines have talked about removing middle seats, rearranging seats. I saw some really creative photos of what a plane might look like for the next few years with the middle seat taken out and barriers around you to help prevent transmission of the virus. I think a lot is going to change, but those are just some of the examples of things that I think we'll be seeing until this vaccine is available. Shawn, any other thoughts on that?
Well, I think from an equity, diversity, inclusion standpoint, there's 2 trends I'm excited about, and then there's one in healthcare. So the first one is working from home, I think is going to feel less of a foreign concept. More and more of us whose jobs can be done remotely, employers will start realizing, hey, maybe it's more productive. But really the positive side effects of it are the fact that it's going to remove some of the constraints in people finding jobs that are not close to them. It may make cities more affordable to live in because not everyone needs to be in the Bay Area, for example, to work for a Bay Area company. So I'm really excited about that, creating access to jobs that otherwise people didn't have access to because you could do those jobs from anywhere, and maybe from more affordable places. The second one is remote learning, access to education. I see some really fantastic things happening in the e-learning space where schools and universities are adopting online classes as a new way of teaching. That, like remote work, also creates access to schools and online courses that people otherwise, couldn't afford to do, either from a standpoint of I can't pay for the tuition, but also sometimes from the standpoint of I can't afford to take 4 years out of my life moving to some other part of the country to go to a campus because I need to take care of people in my family, in my home. So I think virtual access to universities and online courses is going to accelerate, and I think that's going to be a great boon for everyone and our education. In healthcare, the thing that I see that's exciting is we're really moving quickly to figure out more and more of what can be done from home without you needing to see a doctor. So we already talked about telemedicine from the standpoint of having a conversation with the doctor to get a diagnosis or prescription or treatment, but we're also seeing trends in things like at-home drug delivery. You don't need to go to the pharmacy or take time off to go get your drug or get the refill. It can just show up to your doorstep like any other package you get from Amazon or other companies. More and more tests are being possibly done in the home. So you don't need to go and physically get your blood drawn and make an appointment to a lab company. More and more of that testing and sensors and measurements can be done at home, either from the hardware in your iPhone or from a very cheap and affordable peripheral with Bluetooth that can send the data into your phone and share it with the doctor remotely. And that's going to go a long way in not only, again, making telemedicine more effective and making that healthcare more affordable, more convenient, more accessible, but also in shifting healthcare from being reactive to proactive. And that's another thing we talk about, which is instead of waiting for someone to say they're sick and then come to the doctor about that issue, because we're going to have, you know, all these sensors and things checking in on our health every day, and that data being shared with our doctors, they can check in on you and say, hey, your blood sugar's been really off 4 days in a row. Maybe we need to relook at your dose of insulin. Or, hey, your weight's been trending in the wrong direction for the last 6 months. Let's check in and see if there's things we can do to modify your lifestyle. So I'm really excited to see healthcare accelerate towards that future as well. And being stuck at home is forcing companies to innovate on more and more ways that they can service while we're at home.
Absolutely. And just to piggyback on what Sean's saying, I can't tell you how happy patients are to do these telehealth visits. I mean, it was a bit of a crisis here at UCLA the week where we had to transition all of our care to telehealth, telephone. And I was part of that preparation, and the providers were very doubtful that patients would want to engage. Of course, some patients didn't get it, didn't want to do it, maybe even didn't have the devices. And we saw, especially in underserved communities, didn't have the appropriate devices to do a telehealth appointment, for which we could potentially do a telephone, but not a visual appointment. But now all we're hearing is patients saying that they love it. They love that they don't need to drive to UCLA in LA traffic and park and pay $15 and wait in the waiting room and talk to a nurse and then talk to the doctor and get half their questions answered because there's no time. And multiple times now I've heard, it's a little embarrassing to say, but I've had patients say to me on my telehealth visits, well, I actually prefer to talk to you this way. So I do agree that we're absolutely going to be changing how we deliver healthcare, because the patients are going to want it, and it's more effective. And I think I'm seeing some of my patients more often now because it's easier for them to connect with me via their iPad than to come all the way to UCLA.
Yeah, and to piggyback off that, you know, a huge problem in healthcare people don't often realize is not necessarily getting the doctor's orders or the diagnosis, it's actually following the plan. Yeah. So there's so many times where this notion of lack of patient adherence is the reason things get worse. It's not because they weren't told what to do, it's because they didn't understand it or remember, they just didn't follow through. And when you make that access easier, you can make those touch points more frequent. You can help that adherence and make sure they're taking their meds, doing that exercise, modifying their lifestyle how they need to, and that's going to help everyone live longer too.
Thank you both for calling out the silver linings. I think that even through this crisis, there's so many things that are going to change and are going to be our new normal. Shawn, you pointed out the ability to work remote. You know, at Micron, that definitely for us expands our talent pool and our ability to attract diverse talent. So it's really exciting. You all have covered so much. I've learned a lot. At this point, I'd love to open it up to questions. So if anyone has a question, we're happy to take them now.
Hey, Sharon, I see there's a question on the IM about how much of a problem will the vaxxer crowd be?
I'm assuming you mean the anti-vax crowd. I think the question is how much of a problem will the anti-vax crowd be? So if that is the question, I'll try and answer that one. We have a little, and that's referring to the population of individuals in the United States, predominantly in California, actually. I think we're about 50% of the anti-vax crowd, that feels that vaccines are not effective and potentially dangerous. And I live on the west side of Los Angeles, and near one town where actually there's a very high prevalence of the anti-vax movement. We are actually seeing that some of the anti-vaxxers might see potential benefit of a vaccine for COVID. And we think that might be just because of the hysteria that the virus has caused. Although we're certain that there are going to be individuals that are concerned about vaccinating themselves and especially their children, because that's where this population has been concerned about vaccine administration. So we have researchers actually in our School of Public Health that work very intimately with this population, especially in Southern California, and are trying to understand how messaging and education and research about the vaccines can make people feel more comfortable in receiving the vaccines for themselves and their children. But we're also pretty confident that if at least 60 to 70% of the population either gets COVID or gets the vaccine, that we'll have herd immunity. So we're not going to get herd immunity. So herd immunity is this concept that there's so many people who have had the exposure and who are protected from it, that it protects everyone around them. So if there's a population of 100 people, if 70 people in that population have had flu and are protected from it, so this implies immunity from it, that the other 30 people, just by living in the same environment, are also protected. So we can obtain herd immunity two ways. One is by everyone getting COVID-19, which we're trying to avoid with social distancing and everything that we're doing. So we don't think we'll get herd immunity by the current methods that we're using. But over time, and with a vaccine that does expose you with enough virus to give you immunity, but not enough to make you very ill, we might actually get to a steady state that even if there's 20% of the population or so that doesn't have the vaccine, we're all protected. I hope that answers that individual's question, but I can clarify.
Thank you.
Thank you.
Who else has a question?
I have a question. How does lack of representation, kind of how does that play into clinical trials for COVID-19?
Oh, we have a big problem with that. So the way that drugs and vaccines are rolled out are in multiple phases. So usually it's a 4 or 5 phase process. And typically the first few phases, it's a very specific general population that you're testing, mostly the safety of the medication or the vaccine. And then over time, you want exposure of that new product to a diverse sampling that's representative of the larger population so that you can see that it's effective in everyone. So unless we have clinical trials that enroll African Americans, Latinos, low-income individuals, people with different genetic or ethnic or racial backgrounds, we're not going to be able to know for sure whether the treatments are effective in everyone. And one of the great examples of this is there's a hypertension or blood pressure medication several years, actually it's decades now ago, that we applied to the general population and it was effective. But then when people started looking at the data by race, they realized that in Black males, it was especially effective and even more effective than in any other group. So we were in a beneficial way able to help with some of the disparities that we see in Black men with high blood pressure by using that data to give that medication to Black men as the first line of treatment for blood pressure. So getting back to the question, what we're doing with a lot of the trials that we have ongoing, and now I will say the trials are at every major health center, right? We get a lot of calls in our call center here from people who live in more rural areas, and they're worried that they're not going to have access to some of the trial medications. And the reality is these trials are going on everywhere. They're not just in New York. They're now throughout California, they're in Texas, they're even in the middle of the country, a Mayo Clinic. So a lot of people who are very ill and who are eligible for these trials, we're enrolling them. But unless we have people of different races, different ages, different backgrounds enrolling in the trials, it will be difficult to say that these medications work the same for everyone. So underlying the efforts to enroll everyone that we can into the appropriate clinical trials, there are individuals that are making sure that there is representation of every type of person in these trials for when we look at those data. I can't say that it's perfect yet. We've already talked about the access problems, and the reality is that some of these patients who are of ethnic racial minority groups arrive to the hospital so late that they might not be eligible for the trial. But when possible, they're trying to enroll people. The other thing that is challenging, however, is because of a lot of the situations I mentioned earlier, including mistrust of healthcare in general, and unfortunately some horrific things that African Americans have gone through as a community with medical experimentation, so this is Tuskegee and other unfortunate events in our history, African Americans are historically less likely to agree to participate in trials. So that's where scientists like me and other individuals feel that it's very important that we speak to those individuals and say that these trials are to actually benefit them and other individuals that might contract the disease.
Yeah, it's a big problem, not just in the clinical circles of how doctors use data to make their decisions, and these sampling biases of who we're asking or collecting this data from can greatly affect whether we make the right or wrong clinical decisions. It also, when we look at the tech world that is trying to create artificial intelligence algorithms based off of data to help create tools to help doctors make better decisions or help make tools for patients to make better decisions, these AI are also susceptible to the same bias, because the way that tech works is it looks at a data set and it says, what are the patterns and stats I see in this data? And based on that, I'm going to extrapolate some learnings and I'm going to apply it moving forward. If that data itself is inherently biased because it omitted a certain group or overrepresented a certain group, that bias is going to propagate in the intelligence of this new algorithm. And so, you know, as we build all of these new apps that help doctors and patients make better decisions, we have to be super mindful of, is that data representing the general population well? Is it paying attention to the nuance of its potential sampling bias?
Yeah, I think that's a really good point that Sean's making. And that's why when we do research now, we always stratify the research by demographic factors. So whenever you see a trial that's reported, we say overall, was this drug effective or ineffective, or efficacious or inefficacious? But then after that, the question is, what about when you break it down by specific groups? So by age, by gender, by race, by ethnicity. Are there differential impacts of the medication based on demographic factors? And that, believe it or not, wasn't done until pretty recently in medical science.
Well, what that's telling us is that representation really matters. So in that sample size, as you're building AI solutions, which I've seen a number of studies of how there have been gaps just because the group or the data that was collected was not representative of all people. I'm assuming that representation matters too with doctors and those that are providing the healthcare. Can you talk a little bit about that, Sean? I know you shared some stats that showed people that have women as their physician tend to fare better, which I actually thought was really interesting, just as far as making sure we have that equity within healthcare.
It's true. I mean, there's basic levels of representation you need just, again, to create access. Like, for example, what languages a doctor speaks, just so they can meet the patient where they are in the language in which they're speaking. There's representation also of you know, having likeness in ethnicity or country of origin actually helps sometimes inform better decision making, because doctors can empathize better. You know, they may understand things the patient is not vocalizing, like what their family structure may be like, what their at-home culture may be like, what kind of dietary decisions they're more prone to because of where they're coming from or what culture they are, that doctors of, you know, again, like the patient can pick up easily. You know, and then there's the gender thing, and, you know, there's all sorts of stats around it, and it's really hard to tease out why they exist, but exactly, there's stats that indicate female doctors, you know, perhaps because they're more active listeners, pick up on things and have less diagnostic errors than males. There's also, on the other side, you know, males tend to listen to male doctors more. So, you know, I don't have those numbers off the top of my head, Shawn. Maybe we could send it out to the group afterward, but these things do matter. And so the way to address that is giving consumers choice, like letting you pick what kind of doctor you want to see based on who you'll feel most comfortable with, and also making it easy to get second opinions. Some of the best doctors encourage you to talk to other doctors, because that diverse perspective often leads to a better decision clinically. There was a Mayo Clinic study done a couple of years ago that had some startling statistic that said a significant percentage of first opinions are overridden with a second opinion that leads to either a better drug being prescribed or more accurate diagnosis. That's in some ways scary, but also easy to address, right? If we make healthcare more affordable, give people choice, let people talk to multiple doctors to get multiple perspectives, you're going to make better decisions. And again, it speaks to diversity.
Yeah, it's really interesting, Sean. I know we've worked together in a prior life, and one of the things we found with Health Tap that we didn't expect to find with the employee population is that those that were non-native English speakers were more comfortable using the app for healthcare opposed to going to their doctor. You bring up a really good point about being comfortable and the person who's providing you care, them being tuned in to who you are and listening, and that really speaks to the diversity elements of all of us, right? All of our different diversity dimensions and how those play out with relation to health.
I'll give you an anecdote just in my personal life. 2 weeks ago, we have an employee whose father is having a behavioral health issue, and he's embarrassed about it. This person is of South Asian descent, and in that culture, all mental health and behavioral health issues are super taboo and embarrassing. Unfortunately, it was really difficult to find a South Asian behavioral health medical provider in the Bay Area. And this person didn't feel comfortable seeking treatment at all unless it was someone who they could speak to behind closed doors, who would understand these cultural nuances of where he's from, to even have the conversation. So, I think these things really do matter, because if that access doesn't exist with a doctor of your choice, guess what people do? They just avoid care. And that's sometimes way worse.
Right. We have time for one last question. So I'm going to open it up to see if there's anything, Apu, in chat, or if anyone has a live question.
I had one, unless I don't see one in chat, so I don't think I'm stepping on anyone. So I'm curious how much at the forefront this conversation about disparate health outcomes for people of underrepresented race and ethnicity has come to the general medical profession, and has it really changed the conversation around bias mitigation and training and inclusive behaviors and how they develop that, or is it still kind of apart from the conversation?
Sure. No. Thank you for that question. I'll take a go at it first. When I was going through medical school, and I'm going to age myself, which was in the early 2000s, that was right around the time that diversity was the hot topic in medicine. I remember when I was pre-med, it wasn't really spoken about. No one had, as I mentioned, been doing much research by race and ethnicity, but things kind of hit a climax in the early 2000s. And I remember being in medical school and thinking, wow, everybody is talking about race and disparities, and there's disparities in everything. Everything you looked at, there was a disparities. Blacks did worse, Hispanics did worse. And no one was getting to the what can we do about it. It was just a decade long of data exposing the disparities and the differences. And what has happened since then is that we've moved beyond that towards action, intervention, and implementation. And in this field of dissemination science, what we study and what my lab at UCLA does is we actually work in community-based settings to understand not only what disparities are there and how large they are, but what the drivers are and how to combat those drivers. And that's the big movement in medicine now. I don't think that many physicians, especially in large urban areas, were surprised when the data was coming out that COVID-19 had large disparities. That is well taught. It's known that that's a fact. I think fewer providers understand the why. Fewer providers understand that this is deeply rooted in known systemic and societal factors, social determinants of health that have been going on, for 100 years in this country. And I think even fewer providers understand what needs to be done to overcome the disparities. So in medical schools now, there is a lot of teaching towards students to try and understand the history behind disparities in this country, and also this field of dissemination science into how we can alleviate or mitigate disparities. But honestly, that field is so small and so new, and honestly, the solutions are very tough, that it's still considered relatively new within medicine.
Yeah, I would say medical curriculum and medical school training is actually trying to address even a more basic problem right now. So the trend was, for 4 years, you would really train out of a textbook, and then you would practice patient bedside manner and interaction afterward. And this idea of being an empathetic listener, knowing how to interview a patient properly, reading between the lines of their body language, all of these skills are things you don't need to wait for a doctor to start practicing when they're already a doctor. These are things that can be taught and practiced while they're in school. So, you know, a lot of med schools are shifting towards helping medical students get in front of patients more and do more things that require, you know, being empathetic, being an active listener, being a good conversationalist, picking up on body language. And I think that's the first basic step to do before you can then go to a more advanced level of skill, which is unpacking the nuances of your ethnicity and where you're from and how these disparities may play into the care you get. But it's an exciting trend, and it's a positive trend. And I think that awareness is growing. And I think what you're going to get as a result of it are better doctors.
Yeah. And we're really focusing on trying to teach our medical students cultural competency. And, you know, they're humans too. So some of them get it. Some of them develop a passion for it, and they dedicate their career to studying disparities. Others, a lot of them just get enough that they are aware of them, and they watch for their behavior and interactions with patients so they don't treat people unfairly. But then there's other people who it's going to go right over their head. And what we're trying to do is minimize that population of medical students that don't see it. And some of it is forced education through these cultural competency courses we have. But we encourage them to do rotations, which are blocks of education in underserved communities and urban settings. Some at our medical school, we send our students abroad. Unfortunately, we couldn't do it this year, but we send them to China, we send them to Japan. Several of our students go to Sub-Saharan Africa, Latin America. We also send a few students to underserved parts of Europe as well, so that they learn not only about domestic disparities, but also international disparities as well.
Shawn and Dr. May, thank you both so much. We are right at the hour. We could go on talking about this for hours and hours, but I know you all have great work to get back to. On behalf of Micron, we want to thank you for all that both of you all are doing to keep us healthy and well, and our communities healthy and well. So again, we just thank you for pausing and taking time out today to join us.